And I'm Dr. Amber Klimczak.
And we are
Two Peaks in a Pod.
Okay, well, welcome back, everybody. We have a very special episode for you this week, and I have to give Dr. K all of the credit for coming up with this one. Do you want to tell them what we're going to be doing today?
Okay, so we're going to have a little bit of fun this week. So the theme for today's episode is Stranger Things in honor of Halloween. So I love Halloween. How do you feel about Halloween, Dr. Reed? Do you like it?
Gosh, I love Halloween so much too. It's actually sort of personal because my grandmother, she has passed away, but her birthday, she always celebrated on Halloween, and it always makes me think of her because she always made it such a fun holiday and everything. So yes, love it. And we were going to dress up, but we just didn't get it together enough, right?
I had the best Halloween costume.
Okay.
Actually, it wasn't good at all, but it was funny.
Okay. What was it going to be?
I ran out of time. I was going to wrap myself in cardboard and have a big string coming out and be a tampon. Yeah, but then I realized, I'm scary enough with my under eyes.
That would have been amazing. Oh my gosh. Okay, my idea had been we could just both be witches, but yours is way more entertaining.
I'm like,
next year.
This is a very easy costume to do. There's a Michael's right next to our office for those of you all that are near us. So, all right, no costumes, but we're going to go with a Halloween theme. So, probably a lot of you may have heard of some strange things in healthcare. There's even some television series, I think, that cover just rare happenings and rare occurrences in medical. So we know that in physiology, we can have some really strange things happen. So for our Stranger Things episode, I thought we could go over some of the strange OBGYN fertility occurrences that we've seen. Some of these we haven't seen, but just rare, interesting cases.
Yes. Okay. Well, I'm going to start off by telling you about a story. So this was way back when I was in residency, a long, long time ago when I was doing training, and I was working on labor and delivery, and we have the triage section. This is where patients come in if they're having an urgent issue. And so as a lower level resident, I was the first one to see these patients when they came in. So I have somebody come in, she's roughly about 6 months pregnant. She comes in and she says, I haven't been feeling my baby move. And I said, okay, well, let me help you right away. And so I go to get our Doppler so I can listen to the baby's heartbeat, and I can't find a heartbeat. And so I'm starting to stress a little bit, like, why can't I find the heartbeat? I hope everything is okay. But also I'm in training, I'm a resident. I'm like, well, maybe I'm just not finding it. So we go to find the ultrasound machine, and I'm doing ultrasound on her, and I can't see the baby. And that's so embarrassing because she's very far along. Like, you can't miss a 6-month baby.
Yeah.
And so I'm thinking, like, I can see the baby, and I'm kind of embarrassed. And so I'm
bad intern.
I know. So I'm having to go get my chief resident to say, can't find the baby. And they're looking at me like, what do you mean you can't find the baby? Are you an idiot? What's going on? And so they come back, and then they can't find the baby either. And they look at the uterus. Nothing looks like they're in there. They end up running a pregnancy hormone level on her, and it was 0. So she was not pregnant, but she looked like she was about 6 months pregnant. And this was not normal for her. I know sometimes people can just maybe be a little chunky around the waist, but like if you saw old pictures of this person, no, she just looked totally normal. But in this case, she had that very distinct pregnancy belly. And so we, explained to her, we said, I'm so sorry, it looks like you're not pregnant. And she said, oh, why does this keep happening? And she's really kind of mad, saying that that she would just be pregnant and the baby would just disappear, which we know that doesn't happen, right? When you're 6 months along, like, it's very obvious if you lose the baby, like, you have to deliver the baby and all that. And it turns out she had this condition called pseudocyesis, which is a psychological condition where you believe that you are pregnant, even though you are not pregnant. And what's so fascinating to me about this is your body starts to take on pregnancy symptoms.
Very interesting.
Yes.
And so she has had it happen more than once.
But yeah, she said this happens all the time to her over years, and the doctors couldn't figure it out. And, of course, her partner was very upset. It's hard because when you try to explain it to the patient who has this condition, she will just say, no, she won't believe you when you say, no, like you're not pregnant. And, you know, they look back at, you know, records from elsewhere. She had never been pregnant, but in her mind she was. And so, and it's so sad because that was a loss to her. When you believe that that's the case, that was a loss to her. So it was so heartbreaking, but also just fascinating how strong our brains can be in their belief system.
It's incredible. Definitely a rare occurrence, but this is a true medical condition.
Yeah.
I personally have not seen someone with this, but we did have a similar sort of urban legend at my residency about someone who came in with pseudocyesis. So, you know, definitely occurs and it can be really devastating, but a really rare finding.
Yeah.
Okay, so I have another scenario, a stranger thing that can happen in GYN or fertility. So this one I've actually seen a few times. I'm sure you've seen it as well. So I would say the most common time that I see this is we have our fertility patients and we're ready to get started on a treatment cycle. And so we usually get baseline blood work to make sure that all your hormones are nice and low, maybe before we start your IVF cycle or your ovulation induction cycle. And before we start your medications, we get your blood work back and everything should be nice and low. Well, rarely we can get blood work back. And for example, I had one patient, we got it back and she was pregnant. Okay. So yay, you know, like, you're like, okay,
no need for IVF now.
Well, so her beta HCG or the hormone that circulates in your blood when you're pregnant was elevated on her baseline blood work. And so, you know, everyone's like, wow, she's pregnant. We can't start medications. And then you call her, you tell her, you know, it looks like your blood test came back. You have a positive HCG. We can't start medications. And the patient says, no, I'm not pregnant. And she says this with certainty. You know, we're looking at her blood test. She's saying, I'm not pregnant. So what's happening here? Well, this is something called phantom HCG. And pretty common, you know, we can talk about what causes this, but she's having, how does she know that she's not pregnant? Well, she's taking urine pregnancy tests at home and they're negative. So she can say to us, I'm not pregnant. We're getting a blood HCG level and we're seeing an elevation in that number. So that is a pretty telltale sign of what is going on here. So when you have phantom HCG levels, Dr. Reed, do you want to tell them a little bit about what's going on?
Yeah, well, and I guess I would say too, part of the whole urine versus blood that can make it a little bit tricky is there are some times where we have patients where they will have a negative pregnancy hormone level and then they come in and it's positive. Right. It's a true pregnancy, but that could be because the pregnancy is just so early on that it's not showing in the urine. But I think in your case, what you're saying is that the blood level, the HCG level was high enough that it should have been positive on a urine test and it wasn't. And so what this typically is actually interference with our lab assays. So with lab assays, what they can do sometimes is have antibodies in the bloodstream that can interfere with the assay and make it look like it's positive, even if it's coming back negative. And what's really interesting is there are certain people that are more prone to getting this, and we might see this a lot in Texas, which is people that maybe were raised around farm animals. For some reason, they are higher risk of getting some of these antibodies in their blood that can then cause a HCG blood test to be positive when it should have just been a negative test.
Right. And there's two ways that we can delineate and know for sure that this is a case of phantom HCG. Probably the easiest and most straightforward is exactly what this patient was doing. These, we call them heterophilic antibodies or antibodies that interfere with our blood test are not going to affect your urine pregnancy test. So in that case, she does a urine pregnancy test, it's negative, pretty indicative that it's going to be a phantom HCG. The other thing because
we don't usually have antibodies in our urine. We have antibodies in our blood, but not in our urine. So that's why.
And so the other thing you can do is a dilution. And so these antibodies, when they're interfering with the lab assay, if you dilute the specimen of their blood, if it was a real HCG level, it should dilute correspondingly. So if you do a 10% dilution, then it should lower by that amount, etc. But when you try and dilute someone's blood that has heterophilic antibodies, you're going to get the same value no matter what you dilute it by. And that is another sign that you're dealing with phantom HCG levels.
Yes. And then I will say another strategy sometimes I've seen people use is they even just try to get a different HCG assay to use, maybe just a different one to see maybe there's no cross reaction if you use a different lab assay.
Right. Have you, I'm sure you've seen phantom
HCGs. I've definitely seen it from time to time. And, I think it is something that really gets hammered into us during training. And I think the hard part is before, most of us knew about phantom HCG, the problem is sometimes you would have patients, they would come in with constantly elevated levels of HCG. Because it was staying around the same level, they knew it wasn't a viable pregnancy, but then also the doctor was always worried, do you have retained miscarriage products or something that needs to be taken out? And so sometimes women unfortunately underwent procedures trying to treat this HCG to get it out when it just wasn't needed because of a lab error. And so we in our field as board certified OB/GYNs are always really taught to look for this and kind of know the signs and all of that. And I do think it's a really important topic to always think about when these cases come up.
Absolutely. Wow, that's scary to think about unnecessary surgeries.
Yes,
I hadn't really thought about that.
Unnecessary surgery or even chemotherapy.
Choriocarcinoma, things like that. Yeah, so there are certain types of gynecology cancer that will present with a persistently elevated HCG level in your blood. And so then if you are not familiar with phantom HCG, that could be confused for that. So
so you really have to be careful with that. And then just another related one though that I found is because we're taught so much about phantom HCG and how to look for it, I do feel like there's other types of more rare causes that can cause positive HCG besides pregnancy that kind of get ignored sometimes. A big one is pituitary HCG. So our pituitary gland can actually make HCG hormone as well. And we frequently see this in menopausal patients or perimenopausal patients. So I used to see this one all the time back when I was an OB/GYN and I would be taking ER calls.
I was about to say, I hate that ER page.
Yes, people would call and they'd say, I have a 60-year-old with a positive pregnancy test. And I'm like, okay, she's probably not pregnant, guys. This is probably pituitary HCG. And the way to prove it to yourself is you can put somebody like that on a birth control pill regimen, and it suppresses the pituitary. The HCG will drop back down to 0. But it is important to rule those things out too, because you want to make sure you're not missing a tumor or anything like that as well. So that's kind of one that I found probably not as many people know about, but I think it's important.
Yes, I also used to get those calls.
That was a frequent one.
Not always the best call in the middle of the night. When you're trying to explain to someone that their 65-year-old ER patient is probably, the reason that she's at the ER is probably not that she's pregnant.
Right. They say when you're in the ER, they get pregnancy tests on everybody, even somebody with a hysterectomy, even somebody who's 65. So we would get these calls sometimes when it was unexpectedly positive.
Yes. Okay, so I have another scenario. And I think I have been on teams before when this has happened, but I haven't ever managed one of these patients myself. So this scenario happens. So someone gets a hysterectomy and they also get their ovaries removed. So we call that, a BSO. They take out like bilateral tubes and ovaries. Everything's removed for one reason or another. Okay. And sometimes this is done even at a young age on women. And so then they go on living their life thinking, okay, I have my uterus out, I have my ovaries out, shouldn't be, having any more symptoms of that. Then they can present with some strange symptoms like constant pelvic pain, pain with intercourse, and just generally feeling like something's going on gynecology related, but they're like, I don't have any of the parts, right? And often, you'll get imaging and there's a pelvic mass. Okay. And so this is something called ovarian remnant syndrome. I'm sure Dr. Reed's playing like she doesn't know what I'm talking about. But this is another sort of stranger things that's happening in OBGYN. But what we probably think is going on is right when she had her surgery, they left behind some small piece of the ovary. And so you have this ovarian remnant that's actually functioning in, working and causing these symptoms that you have. And then when they get the imaging, they see this mass in your pelvis.
Yes. Well, I will say too, a lot of times we'll see a patient, for example, that maybe only had one ovary taken out, right? We're doing their ultrasound. I go to look at their right ovary, for example, and then I go to look at their left ovary, which had been taken out. The patient's like, Doc, I don't have an ovary over there. But I'm like, I always check.
Yeah.
Because I've seen an ovarian remnant before. Maybe nobody else had ever seen it, but maybe for whatever reason that month it grew a couple follicles or something on it. So I say never rule out an ovary, even if it was supposed to have been taken out. I always check just in case.
Right. And I would say the reason why we may see it and other people wouldn't is a couple of reasons. One, we have really powerful ultrasounds and not everyone really even pays attention to your ovaries. When a lot of times if you get an ultrasound done, they're probably looking at your uterus, things like that. They're not always looking at your ovaries. So one, we're always looking at your ovaries. And two, we give you medications for fertility treatment that stimulate your ovary and make those follicles much more visible than they would normally be. So we cheat a little bit. We can find things that maybe we're hiding.
Well, I have to give you all the credit for these ultrasound machines because I thought I had nice ultrasound machines before. And then Dr. K showed me these other ones. And now I call myself a sonogram snob. Because I'm like, I can only use these now. They're like the Mercedes of ultrasound machines. And once you try that, you just can't go back to any of them.
I definitely was spoiled.
Yeah.
And it's very hard to go the other way. Yeah. It's like driving the Mercedes and then someone's trying to offer you this Toyota. Yeah. And you're like, no,
I only take the best.
Yes. Yeah. But our patients, I think it really helps with patient care, and our patients really love our ultrasounds because you can really see what's going on. I mean, it's really nice to explain to people. Sometimes when you're standing with that ultrasound, they're squinting their eyes looking and saying like, what are you looking at?
I know. I'll say, well, look at this, look at that. And they're just like, I don't know what you're talking about. But with our ultrasounds, I do feel like a lot of times they're like, oh my gosh, I can actually see it.
Nice big screens, really clear picture, really fun for OB scans, pregnancy scans. So that's always fun.
Yeah.
Okay, let's go on to another Stranger Things syndrome. So, definitely had this happen.
Okay.
Similar. I'm an OB resident in triage. In residency, we saw a lot of patients that maybe didn't have care prior to coming to see us. So sometimes they'll be pretty far along in their pregnancy before they come in for any sort of evaluation. And usually it's when they're having some sort of problem, right? They think they're in labor, they're having contractions, things like that. So we have a patient in triage complaining of contractions. What's the first thing you do? You check their cervix, right? And so I'm going to check her cervix, which presumably is usually like a pretty easy thing. When we check someone's cervix, we're trying to see, okay, are you dilated? That's one of the signs if you're having contractions. We want to know, is this really going into labor? So that means like, is your cervix dilating in response to these contractions? So you use fingers to check. And so you have gloves on and you check their cervix and you try and feel, well, like feeling in there, it just like doesn't feel right. It sounds silly, but it's like doing something that you do every day. You feel the same thing every day. You know exactly what you're expecting. Yeah. It's a by feel. I just can't even describe it. Like, I'm just like, I don't feel what feels like a cervix. I don't know what I'm feeling, but like something's not right.
This is probably where all the self-doubt comes from.
Yeah.
Oh my gosh, why can I not check?
Right.
Can I check the cervix? You're like embarrassed after you go out. So
and I was not an intern. I will say that. So we ran the triage as a second year. So I had checked a few cervixes prior to this.
Yeah.
And as some of you may know, OBGYN residency is a hierarchy, as Dr. Reed explained. Sure. You have levels and you fit in your level. And again, you're always kind of nervous to tell someone above you that like something's not right, but like you're not able to figure out what's not right. Yeah. So I go to get an upper level, someone above me in the hierarchy with more experience, figure out like, what am I feeling? She checks. Same thing is like, this is strange. I don't know what I'm feeling. And so we are sitting there kind of walking in and out of the room. I'm sure this patient is horrified that we can't check her cervix, And finally we like, there's 3 levels. We go, now we get the chief, right? So comes in, checks, looks at us and is like, she has 2 cervices. And so we're feeling basically what is called a didelphys uterus. Okay, and so a didelphys uterus is a strange thing that can happen in GYN anatomy where you actually have a doubling of your uterus. So normal, uterus, you should have one cavity and one cervix. The cervix is the opening to your uterus where like a baby would deliver from. Well, if you have a didelphys, you have two cavities and then an individual cervix on both sides. Okay, so if you're pregnant with a didelphys uterus, the pregnancy is located in one side and then that one cervix. But it is, I will tell you, even knowing that there were two in there, still when you're checking, you're like, this,
because which one?
It just, it was very difficult. And she wasn't in labor. So it's not like one of them was clearly dilated, because after this happened, I will say I did have a couple of people that actually delivered with a didelphys. And, once it starts dilating, you're like, okay, this is the side, this is easy to feel. I feel it, But we had to do an ultrasound. You can actually see like the other cavity when you do the ultrasound and everything like that. But it certainly was a surprise to us because she wasn't one of our patients that we had been following all along.
Yeah.
And, patients aren't always the best historians. She didn't mention that she had a double uterus.
Yes. Okay, so I've definitely seen that a bunch too, but I can even take it a step further because I used to work with Dr. Wilson. I mean, she was an expert for all of these abnormalities. And so one of the patients that we saw together was fascinating to me because she did have a didelphys, but she also had double bladders. She had two vaginas. She had two gluteal clefts.
Wow.
In the back. So really kind of, 3 butt cheeks.
Wow.
I mean, it was fascinating. And when we saw her, it actually wasn't even for fertility cases. She had already had kids.
Wow.
And really, she was just kind of seeing us because she wanted us to join the two vaginas together, just kind of more for comfort and cosmetic purposes. But it was fascinating. And, what she had shared with us is she said, well, the doctor said that she started off as twins, okay? But then it didn't split completely. She only split from a certain point down here. And that had caused all these abnormalities. And I would say at first I was a little skeptical because sometimes people say that about something else, which I don't know, maybe I'm doing this too. Sometimes when people talk about dermoids or things like that, they say, oh, it started off a twin, and that's not true, actually. But in this case, it really was true. It's called caudal duplication, and I kind of looked it up, and I was fascinated by it. And it's so interesting because you would never know. She just looked like you and me, just walking around, but, in that one spot, just everything was duplicated.
That is fast. Never seen that. That's fascinating. Never seen that. So she had 2 full vaginal canals leading to 2 separate. Okay. And I'm curious, did you ask her when she got pregnant? Was it always on like the same?
I know. Well, we did ask. We said, are you sexually active in both vaginas? And one was more comfortable than the other for her. So the other one she didn't really use as much. But And then I had another patient. I wasn't directly there for her case, but just kind of it got presented at the conference. I knew about it where she had a didelphys, got pregnant, and during her delivery had a hemorrhage. And they ended up having to do a hysterectomy where they removed the one uterus but left the other behind.
Wow.
She had a spare uterus.
Wow. So, that would be a tough surgery, especially postpartum. It's a lot of bleeding. Wow, really. Definitely some stranger things cases. Very rare occurrences.
Well, and I guess since I mentioned dermoid, should we talk about dermoid? Is that
we should talk about that. That's a great one.
So dermoid is really interesting. So as, people who do ultrasounds, we see ovarian cysts all the time. Most of the time when we see ovarian cysts, they're little fluid sacs on the ovaries. So they might just have very simple fluid in it or might have blood clots in it or things like that. But frequently, we can see something called a dermoid, which is a cyst that has multiple different types of tissue in it that should be in other parts of our body. So they often can contain bone or teeth or fat. Or hair.
The hair is so bad.
The hair. Or even thyroid tissue. I mean, there's so many different things that it can contain. So we're always so fascinated by these. Patients are sometimes kind of horrified, but from a scientist level, we're always just wow, nature is so amazing. And, the vast majority of the time they're not cancerous or anything like that. So it's more of a nuisance to the patient. But I'm sure you've seen plenty.
Oh, yeah.
Because they're pretty common.
One of my favorite things to do when you would take these out is to go to the stat pathologist.
Yeah.
When you are in a big hospital, you can do this and you can go and watch them cut into it. And it's like a mystery ball, like you're like Dr. Reed said, you're just trying to figure out. I mean, really, it's like a ball of hair with like hard enamel, like teeth. I mean, I've seen all sorts of things. They're very strange looking.
And you know what that reminded me of too? The NMD, what is it? NMD psychosis or something. Do you remember how sometimes you can have a certain kind of dermoid that can release a certain type of chemical that can actually temporarily cause you to be psychotic?
Yeah.
I've seen cases of that too.
Oh my
gosh.
It's
just coming back to all these stories.
See, you had Stranger Things cases.
Yeah, and it's so treatable because all you do is just take out the mask and then they just go back to normal. So yeah, these are good.
But like she said, we should tell you that if you have a dermoid, it's not that you ate your twin.
Oh,
it's not a, what is it? My Big Fat Greek Wedding, where she's like, I used to have the twin. It's not that situation.
Yes.
This is like its own stem cell, something is, developing there.
Yes, yeah. Absolutely. NMDA, that's what I was trying to say. That's that can be produced,
Yeah, I do. I haven't seen it, but I do know what I'm talking about.
Yeah.
Okay, let's talk about another one. I think you've probably seen this one. Okay. This is another one, just, at a big institution. I have seen it. So we see a lot of infertility patients, obviously. So there was a couple that have been trying to conceive, couldn't get pregnant, come to see us. And, we do some testing on her, do an ultrasound. You can see small follicles on her ovary, but really her levels seem to be very, very low. Hormone levels looks very much like what we call diminished ovarian reserve. Things just like really seem to be kind of shut down, not good reserve, even though they're young women. She's a young woman. So we start to do an IVF stimulation on her and start her on medications and just does not respond. A lot of times when we have IVF, we're giving you extra hormones. We're trying to grow those follicles. Even if someone's really going to have sort of a bad IVF cycle, maybe not respond nicely, they still do something. Some things can be like no growth of these small, what we call antral follicles at all. Very, very unusual case. And so we look more and more into it, trying to figure out what was going on, higher doses, no response, things like that. So this actually turned out to be a case of Savage syndrome. So Savage syndrome is a nickname. I do think it sounds kind of spooky for Halloween, right? Savage syndrome, I believe it was someone's last name, Savage, who I guess diagnosed it. But what's happening is actually you're having resistant ovary syndrome. So your ovary, even though it has these resting follicles, they are resistant. Their receptors for FSH are resistant to the hormone that comes from your brain, FSH, which is the same hormone that we give when we do IVF. And so they don't have any even, early growth or then ultimately further growth during an IVF stimulation. Wow. It's really interesting.
Yeah, so FSH receptor mutation.
That's the thought behind it.
I guess I just haven't heard that name for it, but that's interesting that it must have been the person who kind of discovered that. Okay, good. And then I guess presumably she must not have been one to have periods on her own or anything because her body wasn't ever able to.
She just won't develop follicles. Yeah.
Interesting. Okay.
Yeah, it's kind of a rare cause and things like that. Okay. This one I definitely haven't seen.
Okay.
But I just do think it's kind of a strange one because I also just think this disease is strange. So, but this is the scenario when it happens.
Okay.
So apparently, we're always taught, check for all STDs as gynecologists, especially if you're, doing OB, planning on getting someone pregnant. So you always have to check for STDs. And we check for gonorrhea, chlamydia, syphilis, HIV. So syphilis is kind of in our basic workup. And so very rarely, I would say, do we ever have a positive. But it does happen on occasion. And when they're pregnant, especially, you have to do a certain type of treatment. There's really no substitute. It's penicillin. You have to do this. And so something really strange can happen when you treat someone for syphilis. Never seen it, but it can happen. And so I guess what happens is you start giving them the treatment, penicillin, and then they start to get really hot and flushed and fever, like they're having this reaction. And this is the really creepy Halloween thing that it is. Okay, so syphilis. Can you tell them what is actually causing syphilis? What is the actual?
So this is a bacteria called Treponema pallidum, and it's a bacteria that can infect your body. And in the beginning, symptoms can be really mild, but really the biggest problem is if this doesn't get recognized early, it can progress over time to be very serious. And so some of the more serious manifestations would be neurosyphilis, where it affects your nervous system, and it's horrible during pregnancy too, because it can affect your pregnancy and can affect the baby and all of those things. And one of the great things is the treatment is usually pretty easy, just penicillin, but you have to make sure it gets recognized so that you can treat it.
Right. So it's this basically organism that they call it a spirochete. But as you're treating with penicillin, you can actually have where they're all released from the cells. And so these spirochetes are released in your body, causing this crazy reaction where you almost look like you're going into like an allergic reaction to the medication. Interestingly, it's totally harmless. It's self-limited. It goes away. But apparently when it happens, it's a pretty nasty response to the medication. The name of this, I'm going to totally butcher this, also two people's last names, Yerich-Hertzheimer reaction.
Okay.
And we did learn about it in medical school. Sometimes it's like a test question.
I think it was on step 1, 2, or 3 or something like that.
But the thought of those organisms getting released into your body.
Yes. Well, okay, when you were first telling the story, I thought you were going to be mentioning, because I'm sure you've seen too, all the false positive syphilis tests we did too. And that's kind of interesting as well, because a lot of times this is how I've been able to diagnose somebody with, for example, rheumatoid arthritis or lupus.
That's true.
Patients like that can get a false positive on their syphilis test. And then the other thing is after COVID and COVID vaccines and everything, sometimes we're seeing higher rates of false positives as well. I think some of the major labs have put out a statement about that too. So that's where I thought you were at first going with this, but no weirder. More stranger things. Yes. Okay, good. Those were some good ones. Okay, I love your idea. This is amazing. We need to do this again next year. Except next year, you'll be dressed as a tampon.
Yeah, exactly. I don't want to know what you have to go as to match with the tampon.
I know. A maxi. That would be a great maxi pad. Okay, great. Well, thank you guys. Hope you all have a good rest of your week.
Happy Halloween.